On this bonus episode of First Case, we're partnering with OR Manager to bring you an exciting educational session from the 2022 OR Manager Conference. If you enjoy this interview and you want to learn more, check out the next OR Manager Conference in Nashville, Tennessee, September 18th through 20th, 2023. You can view the full agenda at ormanagerconference.com, and you can register using a promo code PODCAST to receive a discount. So sit back, relax, and get ready to learn.
So good morning, everybody. How are you? How is the change in altitude treating you? So far, so good. I was sharing earlier that we had there was another clinical conference in Colorado Springs in February, and people kept remarking on how they were feeling that difference. And I said I didn't feel it this time. I might sort of feel it a little bit this time. I don't know, but certainly good to be here. I appreciate the invitation to join the OR Manager Conference. It's interesting when I was working on my content for today, which was back in July. I really wasn't thinking about the timing of October, and we know, of course, it's Breast Cancer Awareness Month. And I thought it was kind of interesting because one of the things that I wanted to make sure that I kind of shared was this whole idea around the story of Henrietta Lacks. Is anybody familiar with the story of Henrietta Lacks? So the immortal life of Henrietta Lacks. She was a black female from Roanoke, Virginia. And in 1951, she passed away from cervical cancer, and it was a very, very aggressive form of cervical cancer. And while she was in the hospital with a number of other patients who were also suffering from cervical cancer. And Johns Hopkins was one of the medical research universities that was requesting to do some, research and analysis of these patients' cancer cells. And this was not, widely shared. It wasn't transparency around the fact that they were doing this. And so, unfortunately, Henrietta passed away, of course, again, tender age of 31. And her cells, though, outlived her. I mean, in perpetuity, even today, her cells just grew and grew and grew. And they were the basis of a lot of research 10 times over that has been done in the medical field and has really been instrumental in solving or getting closer to solving a lot of other diseases. But as you can imagine, there were a lot of organizations that were profiting from her cancer and getting access to these cells and using them for research. And the family, again, did not know that any of this was happening and did not receive any compensation for it. But until Rebecca Skloot came along, they really, again, weren't aware of what was going on, but she wanted to write this story about the HeLa cell, which is what Henrietta Lacks cells have been referred to. And she really wanted to make sure that she told the real story. And of course, there was a movie that was also, a book came out, and maybe if a movie wasn't done, I'm sure there will be one that will come out. But I say all of this to kind of help us think about the fact that stories really do help us to understand each other, give us a way to understand people's histories, and they create a proximity that's so valuable, and especially in the clinical world. So Rebecca Skloot's quote here around, "I keep with me all that I know about you deep in my soul, because I am part of you and you are me." She's really referring to the fact that Henrietta's cells have lived on and are really a part of so many people today, and she felt that connection. When I began this role at North American Partners in Anesthesia, we call it NAPA for short, not to be confused with the winery or the auto parts dealer. We're certainly always hoping people recognize our brand as a care provider in anesthesia. But coming out of the insurance industry for about 20 years, I really became curious about clinical stories, and I started to create this personal library around many kinds of stories, those that are told from the point of view of a physician, those working in ERs and surgery centers and dealing with really challenging issues that were affecting them professionally and personally. Learning a little bit more about somatic abolitionism in the book My Grandmother's Hands, and also just getting a little more reacquainted with some of the more difficult parts of our history around medical experiments that were done in communities of color. So I really became interested in starting to get myself a little bit more enrolled in healthcare and some of these aspects of storytelling. And what I think is so important is when our clinical providers, our care providers, think about what these stories are and what they might mean, it really helps you to start to think about how this shows up actually in a clinical setting. So when we think about the idea of intersectional identities, and I talk about this often at work, we really think about how we show up as many parts of ourselves, not just one part. So intersectional identity is really this commingling of our demographics and our biographies, and they really do shape and really kind of make the output of the work that we all do, whether you're working in a clinical care setting or in a corporate environment, even more meaningful when we are able to see what that does. And I think it also allows us to connect deeper relationships with our peers, with our colleagues too. So today, in our time together, we really just want to think about how to explore and reflect on building a clinical TPOV, or teachable point of view, and to do that by three things: applying narrative medicine, bridging proximity to your origin story, and unpacking unconscious bias. And by doing all of this, it's really going to help you kind of confront and challenge your leadership point of view with an equity lens. So a different way of maybe thinking about the work that you do if you haven't kind of considered how equity plays into patient care and leadership for you. So narrative medicine, I came upon this concept last summer, and I was kind of fascinated by it because, I'm a humanities and social sciences grad and always looking for ways to create a little bit more credibility for, I think, a discipline that might, for some people, writers and artists, and they're not real jobs. But when we think about narrative medicine, it's bridging art and literature, and also in this case, medicine. And oftentimes what happens in medical programs when you are taking a class on narrative medicine, you're actually sitting and writing about your own experiences and starting to uncover what bias might look like for you. And sometimes it's the first time for students that they're even thinking about that. So it's a very interesting concept that I'm appreciating being able to think about and kind of bring into my equity work. So when we look at this, we're seeing that every patient has a story that goes beyond the symptoms they bring into the doctor's office. Patients are more than their pathologies, right? So this narrative medicine is a way of creating some more compassion around that. Rita Sharon, I believe, was one of the first people who really started doing some work and kind of creating this term of narrative medicine. And so you see what this does is it gives clinical leaders this enlarged view of the work they're doing in the OR. How many of you are familiar with narrative medicine? Is this a new concept, or a few maybe have heard of it and have thought about it? Okay. So we really just kind of are setting the context here around why it's important and what it is. So when we think about applying narrative medicine, I think one of the best ways to be a great leadership steward of thinking about narrative medicine is to really frame it with emotional intelligence. And emotional intelligence is all about how we recognize, how we are aware of, and how we kind of control in very judicious ways our emotional responses to things. And so there are 4 domains that live in this emotional intelligence space. So one of them is self-management. So how do I make sure that I recognize how I might be responding to someone else, and maybe pausing before I make a comment, before I say something or give a visual cue that's kind of going to betray what's on my mind, but I may not be quite ready to share. So what does self-management look like? It really helps us to think about not creating a more disruptive experience if we take that pause first. Self-awareness. How much do I know about who I am? What are the things that trigger me? One of the things I like to consider with self-awareness, and I think about this in the workplace, a great coaching colleague and friend of mine, Bonnie Artman Fox, she wrote a book called How Did My Family Get Into the Office? And has anybody ever worked with somebody who maybe has a personality, behaviors that remind you of somebody you grew up with, maybe a close friend? And when you know what those triggers are, it allows you to be self-aware about how you want to react in that moment. So what are those triggers for you? The third component here is social awareness. How are you able to recognize how you deal with things? How does that affect other people in the room? How does that affect your peers, your care team, your colleagues? It's important to know this because as you are creating this collegial, care team, you want to make sure that when you know who you're working with and you know how they respond to you, and if you are the leader in the room, how is that going to play out in terms of the care and the service that you're going to be giving to your patients all day? And then the fourth piece of this is relationship management. How good are you at managing conflict? Are you a person that thrives on that? Are you the person that is a perpetrator of it, or do you tend to shy away from it? How do you manage that in your clinical care environment? So all of these domains of emotional intelligence give you a bit of a window into who you are, how you manage things, and how your words and actions might land on those that you are working with and certainly working for. So it's a way of thinking about that whole notion of how we're bridging our compassion and our consciousness in terms of narrative medicine to a lot of the things that have impacted how we've grown up and how we are showing up in the workplace. So proximity then, very simply here, it's the quality or state of being near. And what we can certainly find is that when we get proximate to some of our truths about who we are, it allows us to mature, I think, a little bit faster in a leadership capacity. It also allows you to be a little bit more vulnerable when you might need to be vulnerable, and certainly is important in that relationship with your patients. Proximity is also important because when we know these things about ourselves, we have a choice to perhaps grow from them, make some different choices. When we see that maybe there are some aspects of how we're using our emotional intelligence, starting to recognize what our biases might be, where that's showing up, the proximity that we have because we're working on these things, we're being intentional about working on development plans that might help us, that proximity is very, very, very important. I often talk about in equity work that when we kind of remain insulated in our own networks, and we're not getting outside of that. So all of the people that we are professionally working with, that we are socially connecting to, they're thinking like us, they're looking like us. We don't have proximity to that and those who are different from us. And that really prevents us from being able to grow and connect. And we certainly know, especially in the last couple of years, what the pandemic certainly did was kind of blow the lid off or take the scab off of what has still largely been very unreconciled in terms of our history here in the U.S. Around deep inequities when it comes to healthcare as one, and then the challenges of racial and gender equity. So proximity really forces us to think about what we know about ourselves and how we also are starting to challenge ourselves around getting proximate to others in other parts of our lives. So when you think about gaining some proximity to your origin story and taking yourself kind of way back to how you got to where you are today, I like to kind of share a little bit about my story. And, here we love and crave narrative. We like to read stories about other people. We like to watch movies about other people's stories. So whether they're memoirs, they're biographies, they're things that we just seem to be very, very curious about. And I think being able to gain proximity to your origin story is another really kind of founding element of how we apply narrative medicine in a clinical setting. So I was born in 1971. I grew up in Beaver Falls, PA. Beaver Falls, PA is about 30 minutes from downtown Pittsburgh, and it's the home of Donnie Iris and Joe Namath. Those are our two claims to fame in my very small town outside of Pittsburgh. And my mom was a single parent, and she was a nurse's aide. So, in the 70s, we, LPNs and nurse's aides, and my grandmother was an LPN. And my sister was born in 1976. And when my sister was born, she was very, very sick. She was born with a rare chromosomal disease, craniofrontal nasal dysplasia. And, there were a lot of problems in terms of, her vision. But even more importantly, she had a lot of intellectual development challenges. And as you can imagine, in the 70s, there wasn't a lot of information available about these kinds of diseases. And my mother was, I think, certainly feeling very ill-equipped to know what to do and how to handle, but, doing the best she could as a single parent. And, I, of course, being the older sister, really stepped in and helped to raise my sister. And she is the love of my life. She is joy personified. She's an amazing person, and I am, very, very, very close to her to this day. Very much a disability inclusion advocate, and it's interesting in the work that I do, how that plays into it. And what I've learned is, my superpower is empathy, because I learned that from helping my mom to raise my sister and just kind of seeing people can be cruel. When I was growing up and I would, be out with my sister, kids, mental retardation, saying somebody was retarded. I mean, those are trigger words for me because it was so derogatory, so stigmatizing. But I have found, in my adult life and in my professional work, that is, my origin story, and my proximity to that is one where I see the value that places on what I do. It's important for me to build trust with my colleagues. It's important for me to build trust with people who are not always on board with diversity, equity, and inclusion. Don't always want to hear about it, don't understand what their role and responsibility is in it. But I find ways to build trust, and I use empathy to do that because I want people to be able to listen. I want to be able to start to lower some of the barriers that people put up when they hear the words diversity or equity. So my proximity to that part of my origin story, and that's just one part of it, right, is really important. So I find that as I articulate that to people, it's just giving an example of, again, where we come from and how we're kind of influenced and shaped by our experiences. So I'm going to ask you to take a few moments and do this exercise. Who am I? When you think about your own origin story, how did you come to be who you are? So I'm going to give you just maybe about 4 or 5 minutes. If you just want to take and write down maybe 3, 4, 5 bullets about how you would answer this question. How did you come to be who you are? What is your origin story? I'll give you a few minutes to do that, and I'm going to give you a chance to maybe share with the person near you, and we'll debrief more largely. But we'll just take a few moments and allow you to do that. And again, it doesn't have to be a dissertation, a few bullets. We're not going to do anything like therapy after this by any means, but whatever feels right and real to you around your origin story. And keep in mind, it doesn't have to be a chronological story. You don't have to start from, when you were born and came into this world. It may surface somewhere else for you. So I'm going to ask you, and you can do this in pairs, why don't you just kind of share what you wrote in terms of what you feel your kind of unique origin story is. And if you want to come over and come with somebody, and my friend in the back here, if you want to come up, you can do pairs. You can be a trio. I think we can probably do a pair here and maybe a pair right here, and we could do a trio right here. So just take just a couple of moments, and feel free if you want to move, you can, and share what you came up with. We'll just take a couple of moments for this, and then we'll share more broadly. Okay, so we'll kind of come back together now. Hate to cut off good conversation. So any personal insights for you about your own bullet points? When you think about how it equates to what you're doing from a clinical leadership standpoint. Did you see a parallel to something about your origin story in terms of how it shows up in your work right now? Does anybody want to share what an example of that might be for them? What really came up for you in terms of what you kind of wrote down about your own origin story and how that relates to your clinical leadership role? Absolutely, 100%. You can model the way, and that could be just huge. So what we heard is, the world is smaller than we think it is. It really is much, much smaller. And you all have the opportunity to influence your industry. And you don't always get the opportunity to sit down and really kind of take that pause and humanize the situation. And that is so critical to the people that you are treating. But it's also a way of connecting back to yourself and why you chose to go into the medical field to begin with. And it's something I challenge my colleagues to think about. Why did you choose what you do? A lot of times when people go into human resources, it's because they what? They love people. They like people. And that is true for many, many people, but there's also a lot of challenges in that line of work. When you work in, the marketing and communications field, you might love, writing and creating a narrative and a brand for an organization, but there's a lot of stress and pressure attached to that. But coming back to why you have come to what you do can be a really, really great kind of North Star for many people as they're going through things. To your point, we're coming off of, we're in this endemic stage now of the last couple of years. I think it's fair to say that. And we're still being challenged by what we went through, right? Something that we're really never going to forget. So it's important for us to pause when we can, which kind of leads us then, when we think about the opportunity to influence your industry, we've got to make sure we understand unconscious bias. And so a lot of what you may have started thinking about this morning and what you wrote down in terms of your origin story, think about messages that you heard, kind of maybe how your values and your beliefs and opinions have been shaped by those experiences. And that is what comes into this unconscious bias space. So these social stereotypes about certain groups of people that individuals form outside of their own conscious bias. We have blind spots. We all have biases. Let's start there. We all have them. So I don't care if people say, well, my parents, they raised me to respect everybody. I love everybody. You still have biases. We don't get away from that. What's important is to start to pay attention to what they are and when they're showing up, because you can control that. So another part of my origin story, my grandfather, my paternal grandfather, he was wonderful. We were very close, and I had, a lot of cousins, but my grandfather and I really connected. And one of the, I guess I will call it a bit of a trauma line in my family, is that, my grandfather was not able to come out. And when you think about, somebody from, the silenced generation, a man of color, again, all of the stigmatizing challenges around being a part of the LGBTQ plus community, just a lot happening there. But when I think about my relationship with him, he was, a great father type figure to me. I remember when I got to my first apartment out of college, he came to my apartment, he brought me food, he brought me curtains that he had washed and pressed, and he hung these curtains up for me, and I was like, wow, I just wouldn't even have thought about, all of the details around doing that. And just a really amazing person. And I always feel this kind of ancestral connection to that part of my origin story, because I hope that he is feeling my energy as an equity leader right now, knowing that I'm doing work that affects something that was a part of his life that he could never really share with his own children. And, that's a bias piece, because, that has shaped a lot of my family members' views around that community. And so they've got a bias against the Pride community because there were a lot of things that they experienced as a result of, not being able to talk to that. So this has so many far-reaching effects. We think about when people are coming in for care and maybe they don't speak English, and we start to create stories that are not true or fair necessarily for the patient. So they may not be able to communicate, with you. Patients that are coming in and part of the trans community, that's another population that does not always receive equitable patient care. It's something we've talked about in our organization. Our Pride Business Resource Group is looking at that and exploring it so that we can start to share that with our clinical leaders and why this is important for you to start to think about what it means to you. So very important for us to start to think about how we, unpack all that really kind of lives in the space. So when we unpack this and we think about how does this show up for you in clinical care, and I just used a couple of examples. Are there other examples that you can think of where bias shows up in the OR? It is not, and thank you for sharing, what you're kind of dealing with in your organization and the safety aspect of it. So what we're talking about here is how do we help our clinicians, kind of recognize that when you have a patient who, has a preferred gender identity, gender expression, we want to give them the respect of using what it is they've given to us, which may be different than what is on their medical data. And so how do you deal with that? Wednesday, this coming Wednesday is International Pronouns Day, and it's a way to, again, create some education around pronouns. So in my Outlook signature on my emails at work and in my Zoom name signature, I put my pronouns, she, her, hers there. And when I joined my organization, I didn't ask, is it okay if I do this? I figure as the equity leader, I'm going to set, and model what we can and probably should do. And so other people started to use that. And then it kind of then generated some conversation, even with our leadership team around, what this means, why it's important. So it creates a great opportunity to have some dialogue. But again, it creates a way for you to connect in with your patients so that they feel like a real person there. Again, not just a pathology, not just a name that may not match up, again, from the data and what they want you to refer to them as. So that's a really prevalent example right now of how this is showing up in clinical care. And we're getting even more, ambiance in our room right now. So any other examples of how bias could show up in a clinical setting? It's courageous and vulnerable to be able to do that, to ask ourselves those questions. Can I be objective? And if I can't, how do I remove myself from this and I can let the person who can be objective, into the room? So, really important to know, again, we're bringing all of ourselves into work. We're bringing all of those experiences, lived experiences, opinions, beliefs, values, biases in. So we really want to understand, and healthcare especially, how that is going to show up and affect somebody. And then this other piece around, just asking somebody, what are your preferred pronouns? If that feels like it's the right thing to ask in that moment. We let fear hold us back so many times in these conversations. We don't want to look like we don't know what's going on. We don't want to look uninformed. We don't want to be embarrassed because we're used to being the experts in our fields. But, life is becoming much more nuanced. We are complex and layered people. And so we need to give ourselves the grace to continue learning, because to your point, I think that somebody mentioned, not all of this was available to you when you were going to school. You weren't having all of these conversations. And so now it's coming in. We want to start to refresh, I think, our curricula with more of this. And how do we start to help even our experienced clinical professionals, really start to understand and unpack this. But let's not let fear hold us back from being able to just check in with ourselves and certainly with other people. Thank you for the sharing. And please feel free if you'd like to move on up. We're happy to have you in the room with us. So just putting that out there for you. So we've talked about narrative medicine. We've talked about how to apply it, how that understanding of our emotional intelligence is important, and how we think about our kind of unique origin stories and what that means for clinical care. When we think about bias, we also need to understand social determinants of health. Again, a facet of health equity that we can't overlook. And when we think about social determinants of health, these are all of the ways that people are living and working and playing, when you think about that context in their communities. And so if you don't have good access to quality health care, if you don't have access to quality education and employment opportunities, if you are dealing all of the time with violence in your community, you're dealing with racial trauma, these are things that affect quality of life and the outcomes. And again, they keep us in this systemic space of inequity. It persists because we don't see where people have the same experience. Maybe you don't have access to safe housing or good transportation, public transportation perhaps. Neighborhoods, might feel a little less safe and secure. Language and literacy skills. When we think about people, I mentioned if English is not your native language, how hard is it for you to find good care, to find a doctor, to get treated? So these social determinants of health, I consider this a platform that I, really, want to leverage much more in my role because it's so, so important. All of this, it's interdependent, right? It's interdependent. So we need to understand, especially when we kind of think about kind of cluing in, we look at the access to nutritious foods and physical activity. And what's happening right now with young people, with children? What's happening in terms of their physical activity? They're sedentary because, we've got, these little computers in our hands and, they're not doing what, when I was growing up, you were getting out, you couldn't stay in the house, you had to go out, you had to play, and we kind of take that for granted now. And we're all guilty of this, right? So, when we have, less physical activity, that starts to perpetuate certain behaviors because if we're not physically active, we don't have access to good grocery stores, the right kinds of food, all of these other health issues then start to come up. And that's on top of any genetic predisposition you might have. So it's just, how do you clue into all of these social aspects, the whole person? These are all things that really come into play when it comes to health. So medicine's historical context. If you don't know, again, some of our history has been, medical experiments that have been done in communities. When we think about Native communities, communities of color, and the syphilis experiments that were done many years ago. When we think about the relevance of that to today, how do we bridge those histories to the people that have been marginalized? What did you see in the last couple of years that starts to help us kind of recognize what that disconnect might be for people? So in the middle of COVID, what was happening for some communities? Okay, well, that wasn't what the example I was thinking of, but that was definitely something that was happening. Divorce, mental health challenges, if you had caregiving responsibilities before the pandemic, that became even more challenging. Now you have to be, an employee and a teacher because now you're trying to be the teacher at home with your kids. But we were seeing, where I was really going with this, was vaccine hesitancy. Why was that happening? Yep. The Asian communities, yes. Violence, absolutely. So we saw all of these things coming up. So violence, and I will say this, I often talk about 2020 as the year of the twindemic, global health crisis and racial reckoning. And then we also paired, with that later in the year, a very divisive political election. So we were going through a lot of things. None of them new, though. It's just that we were put in this position. We were all, being deployed to either, our workplaces. If you were on the front lines and you were a first responder, you're providing care, or you were being deployed to your home to work from there, and you were just confronted with this in a much more acute way than we had been in a long time. So thinking about those difficult and kind of tragic issues around those experiments and vaccine hesitancy, people were like, you know what, I don't know if I trust what they're going to put in my body. I'm not certain. And so people were, in some cases, choosing not to get vaccinated. That, as we all know, was creating a lot of complications. And, that is history's impact on patients means that we were having so much trouble getting control of this virus. It was so widespread, people were feeling very misinformed and afraid. So medicine's historical context, has real meaning. And if these are, if it's unfamiliar to you about some of the things that have happened, it's a good thing to kind of explore. Because again, that helps you to be a good messenger and a champion, for how to talk about, the importance of vaccines, and how can you help people recognize why it's so important, especially during the time of a pandemic. So I kind of want to bring us now to this idea of a teachable point of view. And this came from a book called The Cycle of Leadership. I was exploring this in my earlier career because I really come from a human resource development background, a lot of classroom facilitation and training. And we were working on a leaders as teachers model in my former organization, and I was exploring that. And I really liked this idea of a teachable point of view, because what I've found in equity work, when I really want to encourage people to start to connect with others. And so if I share a story, or if others share stories, I find that people, and I will say people who are white will struggle sometimes. It's like, well, I'm not part of the pride community, or I'm not Black, Asian, Latinx. I don't have a story. Everybody has a story. We are all unique. We have our own stories, and it's still valuable to bring that in. You don't have to be part of an underserved community to add value and create a teachable point of view. But what I think the struggle is when people maybe don't sit down and really think about, well, maybe my family has an immigrant history that somehow, I bring into my life and into my work, and I hadn't really thought about it that way before. Where I grew up, you might be a big part, your geography, whether it was in an urban environment, the suburbs, or a rural community. You went to a small school, went to a bigger school, come from a big family. These are all things that play into your point of view and your kind of perspective, on the world and what you do. So there are several pieces to creating a teachable point of view. One of them is ideas. So when we think about ideas, what is your intellectual understanding of how you feel it's important to win in the work that you do? If you're working with teams, if you're leading teams, how do you think about how ideas come in to the workplace and the clinical setting, to really think about what does it mean when we are winning at this healthcare game, if you will? And not that it's a game by any means, but how are we winning when we're doing it right? So what are those ideas that help us get to that place? Values. What is it that you want to think about in terms of how you want people to kind of behave and conduct themselves in a clinical setting, in a clinical environment? Where does that show up? And doing an exercise like the one that you did moments ago might be a way of helping your team be able to start thinking about that. But what are those values that are going to be most important to you in a clinical environment when we think about equitable patient care? Emotional energy. What are the ways that you can start to think about motivating those people that are working around you, with you, for you? How do you get them to buy into your ideas? So you take these ideas, you take values, you take emotional energy, and all of that leads to edge. It leads to how you start to figure out how you make important judgments. And I'll use the word judgment, not decisions, because you do have to make judgments in a clinical setting, right? You have moments, I'm sure, where it's like you've got to make a judgment. You've got to make a call. So I'm going to just go off script here a little bit and say, there are so many franchises on network television now around, medical environments, hospitals, and I think it might have been Chicago Med I was watching the other night, and there was an example of, the challenge we're having with the supply chain and, pharmaceuticals. And so they had a patient that was having a reaction and needed a drug that the hospital couldn't get access to. And so, one of the clinicians, kind of pulled the surgeon aside and said, I have a friend that I could get what this person needs. I could get access to it. And of course, the surgeon is saying, that's ethically, we cannot do that. We absolutely cannot make that happen. It got to a point where they were not going to be able to get this drug that this patient needed. And so, this clinician made a decision to make this available. And, that's a judgment that has a lot of ramifications to it, right? But how do we create the space and have the right kind of conversation? And how do you do all the things that build up to that? One of them being what the values are in your clinical setting to help people make the right kind of judgment and decision, if you will. So a lot of this too, when you think about a teachable point of view, it's about you being able to be a teacher and a leader in that setting, but you also want to learn from the people that you are teaching. So how do you create that level of synergy as well? But this is a platform that you can think about developing that might kind of help to amplify the message and the values and the philosophy that you want to bring into your clinical care setting. One example that I just really was impressed by that I saw during the pandemic was the University of Pittsburgh Medical Center, their class of 2024, their School of Medicine, that class decided to write their Hippocratic Oath because they were so affected by what was going on in terms of, the pandemic and racial trauma, and they felt like they needed to make a commitment to the kind of care they were going to be giving to others. And I just pulled out a few of the bullets from the oath, and you can always go out online and Google this. But, some of the things that they said in this oath: I will be an ally to those of low socioeconomic status, the BIPOC community, the pride community, women, differently abled individuals, other underserved groups, in order to dismantle the systemic racism and prejudice that medical professionals and society have perpetuated. That's deep. They're really going to be intentional and purposeful about this. Educating myself on social determinants of health in order to use my voice as a physician to advocate for a more equitable healthcare system. Restore trust between the healthcare community and the population in which I serve. Embracing the ever-changing responsibilities of being a physician and pledge to uphold the integrity of the profession in the clinic and beyond. These are really, really powerful commitment statements. And so I share this with you as an example of even something that you can do. Not that you have to go and write your own Hippocratic Oath, but think about what your own pledge to equitable care could look like. Maybe it's an exercise that you do with your team. Again, it's a reminder of what is important, what is shaping your values and your care today. Because we're in a very dynamic time. If we haven't learned anything else from the last couple of years, we know how to be resilient. We do know how to do that. But change is fast. It's coming at us all of the time. It's health issues, it's war, it's, dealing with gun violence, politics, it's all coming at us. So how do we start to really kind of fortify ourselves and our roles with something that we feel is very foundational to go back to? So now is the time One last writing exercise for you here is to think about what you feel like your clinical TPOV might be. So you've thought about your origin story. You're thinking about where bias might be coming into play for you as a clinical leader, thinking about this importance of narrative medicine, how we're kind of drawing together literature, writing, medicine, and what that might mean for you in terms of care and equity. So when you think about your TPOV, how do you take self-bias and patience and think about how that informs your teachable point of view? So I'm just going to ask you just to take a couple of moments and think about if you were to write one statement around what might kind of be a context for you in terms of a teachable point of view, what might that be? Something that you feel you would want to share with your colleagues, or if it were to be, put up in the OR, what might that look like for a patient to see, or in the recovery room? What does a teachable point of view for you individually look like? I'm just going to give you 2 minutes to think about that. Maybe jot down what that might mean for you. You're not going to have to share it, but I'll just give you 2 minutes to think about that. What is your clinical TPOV right now? So you started to think about, what that point of view looks like for you. What are some insights or takeaways that you feel you have as a result of what you've heard in our exploration and reflection today? What's a takeaway or two, an insight, an aha, that you feel like you want to take this back and put something into action, or you want to noodle on it a little bit more? I'll ask everybody just to share one or two things that might be resonating for you right now. Why don't we start in the back? We'll work our way up. Would you like to share? Oh, and I'm sorry. We do need to. We're going to get the mic at this point.
I've had several different perioperative type roles. And I knew I really loved my current job, but I don't think I'd really delved into why I enjoyed it so much. And as we were talking, in my family, I'm a first-generation college student. My parents got married very, very young. We joke that we're more like siblings than we are like they're my parents. And so I grew up with this where there's a will, there's a way sort of mentality. My parents never gave me any option. College was what happened after high school. You had to figure out a way to get it paid for. Kind of way of going about life. And so I always think there's a solution to every problem. So when everyone else says, oh, well, we can't do that, or we've tried this before and it failed, I'm always the person that goes, oh, there's another way to do that, or we can find a different way to do that, or we don't have the right people at the table. And so I think I was raised as a natural born facilitator. And so it plays into my current role wonderfully. And I didn't really think about why that led to such high job satisfaction. But I really think it makes a big difference. I truly believe in, I have a surgeon, it's really funny, who stood up in a meeting the other day and looked at my coworker and I and said, you're the first two people I think I've ever met that I have no shadow of a doubt you're doing the job you're meant to do. And I never thought about it that way. So kind of between that and our discussion, it made me see things a little different as to why I really love my job.
Great. Thank you so much for sharing that.
Well, I think I want to be more open to, or I shouldn't say open, but my pledge is more to be open to listen and learn from those diverse experiences. Because I do find, in what we've talked about today, I do find a lot of colleagues who aren't really open. They really aren't. It's just like, is this something that this topic on diversity, is it just going to go away? I mean, people actually will express that to me, and I think, it's sort of offensive to me, but at the same time, it's like they're saying it to me because they, just like you were talking about, they see me as they're part of their greater group.
Yep. And, that just leads to collusion, because people do make that assumption that, hey, you look the same as I do. We think the same way, right? And then it becomes a major surprise when we might challenge them. So I'm getting the nod that we have come to time. And so now my friends here who didn't get a chance to share, we could always offline. But I want to thank all of you for for showing up today and for using this opportunity to kind of explore and reflect on what we shared, and I'm sure you'll do a little bit more of this after today. But I am going to leave you with something that will be your moment of Zen before you leave the session today. So this is my meditation for healthcare professionals. May you be grounded in your conscious self-awareness. May you be rooted in your unique origin story. May you be inspired by your curiosity and capacity to learn more. May you be brave, hopeful, and energized by life. And may you be amazed by the patients you serve. So thank you, everybody. Again, so great to have you all here today, and I look forward to connecting with you after.